So welcome to this presentation about sleep breathing disorders, particularly something called obstructive sleep apnea. So hopefully by the end of this presentation you'll have a good understanding of sleep disorder breathing, and particularly something called obstructive sleep apnea, what the risk factors are and the signs and symptoms. So some people will have a lot of the symptoms of sleep apnea, some people will not have many at all. It doesn't mean to say they haven't got sleep apnea, but if you've got no symptoms at all, then you haven't got sleep apnea syndrome, and that's where the syndrome is in brackets there. I'm going to have a little look at some sleep studies and what we'll look for in a sleep study, just to get you to understand what some of the numbers we sometimes talk about are. A little bit about treatment, what you can do to help yourself, and some of the more formal treatments. And then we're going to talk a little bit about driving and DVLA regulations, and hopefully a lot of people worry about this, but hopefully you'll be able to put your mind at rest for most of you. So this slide is just an overview of different types of sleep disordered breathing. So sleep disordered breathing is an umbrella term for a number of different breathing problems that people can have whilst they're asleep. So most of you will have snoring, and this is a sign that there's some obstruction in the airway right at the back of the throat usually, but it can be simple snoring, can also be in the nose. In people with just simple snoring though, this doesn't actually cause any problems with oxygen levels, so you're still getting air in and out of the lungs, and the problem is more usually for somebody else who's in the same house as that person, particularly a bed partner, but it doesn't usually cause any issues to the sufferer themselves. Upper airways resistance syndrome is similar to snoring, so there's still some kind of obstruction or resistance in the airways, but this can be causing a person to keep waking in the night. It can be very brief and you don't realise you're waking, but it can cause then you to be very sleepy and tired in the daytime. We're going to go into much more detail of obstructive sleep apnea because this is the condition that we're really talking about today. And I've just put on there in brackets syndrome, because you can have obstructive sleep apnea, meaning that when we do a sleep study we can see these apneas, which are basically stoppages in airflow, so you're not getting air in and out because of that obstruction for a short period of time, but you can have that without really having much of a symptom. And so if you have the symptoms, particularly symptoms of being excessively sleepy in the daytime, you have obstructive sleep apnea syndrome, whereas if you don't have that daytime sleepiness, then you've got obstructive sleep apnea, or we sometimes just call that sleep disordered breathing. It gets a little bit complicated. It's not always that clear, so don't worry about it too much. The time that needs to be more thought about is if there are issues with driving, which we'll come to later. There is something called central sleep apnea, which being different to obstructive sleep apnea, there's no obstruction in the airway with this, but what is happening is that drive to breathe that comes from the brain, so the control of the breathing by the brain is disrupted, and so there's a pause in that airflow and the pause in the breathing, just because the brain's not telling the muscles of the respiratory system to move. I've put a little picture of a heart on there because that often occurs in patients with heart problems, or should I say it's more common in patients with heart problems. You can have a lot of patients with heart problems don't have central sleep apnea, but the ones that do have central sleep apnea are more likely to also have heart problems. But it can occur in other situations. It can occur in patients who've had a stroke. It can occur in patients that are taking a lot of painkillers, and particularly opioid type painkillers. And we then do have some patients that have central sleep apnea and we don't really know why they've got it. And then I've just got on the bottom here, it's not something we're going to go into today, it's something called nocturnal hypoventilation, which basically means under breathing. And this can occur in people who are very large, and it can also occur in certain lung conditions, particularly COPD. So what happens when you've got obstructive sleep apnea? Well, we'll start off when we know we've got an open airway, we can talk and we're breathing fine. And you can see in this slide air coming in and down into the airway. When we go to sleep, everything relaxes, all our muscles relax, and that includes those muscles in the upper airway. So that's what UA stands for, the upper airway, which means this airway right at the back of the throat. So we get more resistance in that airway, and the reflexes that help keep that airway open are reduced. This leads to a narrowing of that airway, and that occurs in everybody. That's just a natural phenomenon of sleep. But then if we've got something that can press on that narrow airway, so what I'm calling an obstructive factor, so these are kind of extreme sized tonsils you can see here, but for the majority of people it is excess weight that's been held in the neck or sometimes in the tongue, and not always that visible. This can then press on that floppy and narrow airway and cause it either to fully or partially close off. If we're not getting air in, our oxygen levels go down, so we get something called hypoxia. And if we're not getting air out, our carbon dioxide levels, so that's our waste gas, goes up because we're not getting rid of it, and this is a condition called hypercapnia. Now our brain senses these two gases and these two things, and that make you try harder to breathe, so what we call an increased ventilatory effort. So this is going to send stronger and stronger signals for you to move your diaphragm and your chest to try and increase that space and draw air into your lungs. But because that airway is blocked, this still doesn't work. So eventually that effort causes us to have what we call an arousal. So this is a brief awakening. That brief awakening sends what we call tone back to the muscles of the throat. So those muscles become firmer, open up, and the airway opens up again. This happens so quickly that we don't normally know that it's happened, and we fall straight back asleep, and it can cycle over and over again. And of course, if that's happening over and over again, this causes what we call sleep fragmentation, so really, really broken sleep. And for many people, this can lead to the most common symptom of sleep apnea, a feeling of not having slept, even though you might have been in bed for several hours, waking with what feels like a hangover. You could, and you can feel tired and sleepy in the daytime. So here's a little movie of what's happening in the airway when we have an obstructive apnea. So we've got an open airway and the muscles relax, and we can see things starting to press on the airway and the airway starting to narrow right here. Now we're seeing vibration, so we would hear some snoring. And eventually that airway can completely close off as it has now, so none of this air can go through down into the lungs. So the brain's detecting that there's the oxygen levels are going down, the carbon dioxide's going up, and it's making you try harder and harder to breathe. So eventually we get that wake up, the muscles become firmer, the airway opens, we get more breathing, and it cycles again, and we have another one, and this can repeat over and over again. So for those of you who've never seen sleep apnea, this is what it can look like. So when this person this chap's gone silent. This is probably, there's no air moving, but you can see that his chest and his abdomen are starting to actually move in opposite direction to each other. So he's really trying. His brain's telling him, breathe, breathe, breathe. Come on, you need to breathe. Let's make some effort. Until eventually he's really trying now. And then what's happened there is his brain's woken him up and opened up that muscle. And then he'll fall back asleep. He doesn't know that's happened because he's not woken up fully. But if there's any partners of patients on here, this is the sort of thing that you probably are seeing, and it's, you know, it's understandably quite scary to see. So there are a variety of different causes, or what we call predisposing factors, so things that are going to make it more likely that you are going to have sleep apnea. So there's some things we can't change for sure, whether you're male or female. So males have a more high risk factor, increase in age, particularly once over the age of 50. But there are some things that we can potentially change. And the most common cause for sleep apnea is obesity. It doesn't necessarily have to be obesity. It can just be that you're holding weight in the neck or in the tongue, whereas you could be otherwise relatively slim elsewhere. And if you just look at the little picture that I've got at the top of the screen, hopefully you can see these two people have the same, what we call body mass index. So that means that their weight relative to their height is very similar. But if you can look at the tongue here, this person has a lot of tongue fat, and you can see the fat, what we call subcutaneous fat, in the neck, and that makes this airway, the dark bit here, much narrower compared to this person who's not holding their fat in that particular place and has a much more open airway. This person's got a very severe sleep apnea. This one is only quite a mild sleep apnea. There are conditions. This patient's got something called macroglossia, so a very big tongue, from a condition called acromegaly, where there's too much growth hormone, and you can see why that might help block off your airway. Something that's probably more relative to whether or not you're going to get sleep apnea than something like a body mass index is your neck circumference, and that's why you probably had that measured when you did your sleep study. So the larger your neck circumference, the more likely you are to have sleep apnea. Alcohol, I'm going to go talk about a bit more when we look at treatment of sleep apnea, but alcohol is a muscle relaxant, so that will help close that airway off. So we do have things like changes or the shape of our anatomy in the palate, and people who have a very, what we call a crowded oropharynx, can get sleep apnea, and people with craniofacial abnormalities, so people that have got not much of a jawline, so either a very small or a very set back jaw like this person has, you can see how maybe that could easily fall back and that they've not got a big airway space at the back here already. And then if you have problems with breathing through your nose, mouth breathing in itself can help that airway to collapse. So if you can't breathe through your nose, then that can be promoting you to collapse the back of your airway. So it is important that if you're able to breathe through your nose, you try and get in a regular habit of doing so, because that will help protect the airway at the back there. So I've just put this slide on to show various different other diseases and conditions that people with sleep apnea often have. So these are known as comorbidities. That means these two conditions or multiple conditions often are seen together. It doesn't necessarily mean one causes the other, but it does mean they're often linked. We know with sleep apnea in particular, it is very much independently linked to high blood pressure. So many patients with sleep apnea will have high blood pressure, and particularly those with poorly controlled high blood pressure, those needing lots and lots of medications to get it under control, likely if they've not been diagnosed with sleep apnea would be if they had a sleep study. So what are the symptoms of sleep apnea? What do we look for? Commonly do we see? So this is from the NICE guidelines that were published a couple of years, well, 3 years ago now. And we can roughly break up the symptoms of sleep apnea into daytime symptoms and nighttime symptoms. Like I said previously, you may have all these symptoms, you may actually have none of these symptoms and question the results of your sleep study. So the nighttime symptoms, we also mentioned, most people with obstructive sleep apnea have snoring. They might have a partner that's witnessed these breath pauses and this choking sort of that we saw on the video. Patients sometimes can even wake up gasping or choking for breath. It can often lead to a sleep fragmentation or actually people struggling really with insomnia. Sometimes this can be because they're so sleepy in the day, they're sleeping in the daytime and struggling to sleep at night, but it can be sort of more true insomnia where people just are really struggling to get off to sleep and their sleep is very fragmented. A really common one that people don't often realise is a symptom of sleep apnea is something we call nocturia, which means you're waking up to go to the bathroom, needing to go for a wee in the night. Normally we should have changes in our hormone levels that mean we don't fill our bladders and need to get up to go to the bathroom in the night, but when we have sleep apnea that gets disrupted. In terms of daytime symptoms, then we can have unrefreshing sleep, so we don't feel like we've had a good sleep when we wake up. Some people can wake up with a headache, and if you're getting a headache which sort of you wake up with but goes away once you're up and sort of walking about quite quickly, then that can be a sign that you're holding on to some carbon dioxide, and it's important that you do let us know if you're having that symptom. You might just feel tired in the day, or you might actually be falling asleep excessively. So falling asleep whenever you're not really doing very much. If you're watching TV, it can be really severe in some people where you can be doing it where even when you're engaged with something, you're finding yourself falling asleep. And then for some people it can be having problems with your memory, problems, just sort of a real brain fog. You're struggling to do what you want to do and think straight, and this is a sign of poor sleep. So how do we assess if somebody's likely to have sleep apnea? Well, a lot of you will have been referred by your GP because you've had some of the symptoms of sleep apnea, but some of you will also have been referred as part of a pre-op assessment. Because sleep apnea is a risk factor for having a general anaesthetic. If you think I said the way you get breathing again when you have these breath pauses is to wake yourself up. If you've got general anaesthetic in your system, you don't have that ability to wake yourself up. And really the biggest risk factor is that the anaesthetist doesn't know you've got sleep apnea. So it's not necessarily always that you have to be on treatment before you can have an anaesthetic, but it is important that the anaesthetist know that you've got sleep apnea, and they can make sure that your care after the operation, what we call your perioperative and post-operative care, is in an appropriate location, and they can look at which drugs they need to give you. So the pre-op clinic use this thing called stop bang, and so you get a mark or a point for each of these different observations with the acronym stop and bang, and you get a risk from how many points you score. So if you've got less than 2 of these, you probably aren't on this call. You're considered low risk and you probably wouldn't have much sleep apnea. If you've got more than 5 of these, you are at high risk of having a moderate or a severe level of sleep apnea and would have been sent for a sleep study. So what is a sleep study? Well, actually, it's probably a misnomer because we don't actually measure sleep in the studies that we do, although some of them give us a sort of surrogate for sleep. But what we're measuring, this is just showing you something called a flow-based study. And this is somebody with quite normal breathing. And this is just a sample. This is time. This is this person on the right-hand side. This is their audio volume, so we're not seeing much on here. Their activity levels in this blue line are quite slow, not doing very much. This is their airflow with every breath. So you can see they have a nice regular breathing. This is their oxygen levels, which is nice and stable. Their pulse level, which is pretty stable. There's a little bit of fluctuation, which is normal. We get an increase in heart rate when we breathe in and a decrease when we breathe out, but that's just a normal fluctuation. And then this is the effort that they're making. So we've got a band on the thorax across the chest and one on the abdomen, which is across the belly, and we can see nice steady breathing. So this study is from somebody that does have obstructive sleep apnea. So if I just take you through these events. So this is your airflow. So we have airflow, and then we can see the airflow stops, which is an apnea. We also have these things called hypopneas, where we still have some airflow, but it's much reduced. And we can see with that, we also have drops in oxygen. So this is the oxygen levels going down, but they come back up again as the airflow resumes. There's a little bit of a delay in the timing of how we can pick this up though. We can see that there's still effort, so we know this is obstructive sleep apnea as opposed to central sleep apnea, where we would have no effort going on when there's no airflow. We also know this is an obstructive sleep apnea because we can see this snore that's been picked up on the audio channel when the airflow resumes. We can also see bigger changes in the heart rate, so we see these big jumps in pulse rate when the apnea, sort of the relief of the apnea, we get a big spike in heart rate, which shows that arousal, that waking response. So we get this measurement called the AHI, or the apnea hypopnea index. So what this is, the number of apneas, which is that full on closure, and that needs to be at least 10 seconds if we're measuring it on a flow study, or a hypopnea divided by the number of hours. Ideally it would be sleep, but often it's the number of hours of the study, although we do adapt the studies where we can see somebody's clearly awake and we take that out of the analysis, so we're getting as close as we should be to a true apnea hypopnea index. And this then gives us an idea of whether you have sleep apnea or not, and how severe that sleep apnea is. So it's considered normal if you have anything less than 5 events per hour, and then we have mild, moderate and severe levels. So you might have been told what your number is and be able to categorize yourself by this, but what we do know is that the severity, as we look at it on the apnea hypopnea index, does not reflect the severity of symptoms when we talk to somebody and measure their sleepiness by that Epworth score that you'll have all filled out about how likely you are to fall asleep in situations, or about how tired you can feel. So somebody with a very mild sleep apnea on their AHI can be very symptomatic, and equally we can get people with a very severe AHI who don't report much in the way of symptoms at all. And just to illustrate this point, I've just put this is on from a patient who actually, by the apnea-hypopnea index, it was 0.7. So we would say that this person doesn't have sleep apnea, but they had all the symptoms of sleep apnea. And what we can see on this study is that they're having lots of spikes in their heart rate. So this is the red line here. And this is likely what's causing them to have the symptoms of not refreshing sleep and sleepiness in the daytime. And we did actually treat this patient as if they'd had sleep apnea, and they're getting on really well with the treatment and feeling a lot better. Hopefully you can see the difference with this study. So this is somebody with a very severe sleep apnea. So they were having 93.5 events per hour, so sort of 1.5 events per minute, or 3 events every 2 minutes. I've put on here as well, this orange is actually their snore level, so it's going beyond 70 decibels, which is probably the sound of a washing machine. And you can see that they're very disturbed sleep, they're changing body position quite a lot. They're having really low oxygen levels. This bottom line is 60% of oxygen. Normally it should be about 94, 95 when you're asleep if you've got healthy lungs. But you can see this person's having very, very severe dips in their oxygen levels, and it's very repetitive. It's going on and on pretty much all night except for this little period here. We can also see their heart rates up and down, so this red is quite a thick band compared to the previous one where actually there wasn't a lot of heart rate variability constantly, but that other one just had spikes. So how do we manage sleep apnea and sleep disordered breathing? So this will depend upon your symptom severity of what you want to do. So if you are very severely have a lot of symptoms, then we're more likely to be more formal treatments than if you have very few symptoms. It will also depend on how severe your disease is and the characteristics. So if you have a really high AHI or you're having really large dips in your oxygen levels, that puts you at more risk of the consequences of not treating sleep apnea. And the consequences of not treating sleep apnea when you've got a very severe disease is that you're more likely to have high blood pressure, and you're more at risk of things like strokes and heart attacks. That said, we also want to think about what your risk profile is. So if you're still quite young, you don't have high blood pressure, you don't have any other risk factors, then again, we might look at how we treat you differently, or how you want to be treated differently to if you have a very high risk factor, because we want to minimize that risk. But at the end of the day, it is obviously patient choice. So it's your choice on what treatment you want to go with and how you go ahead with that treatment. So the first line of treatment, and this goes for pretty much everybody where it's applicable, we should be treating sleep apnea with lifestyle changes to try and minimize the cause and get rid of the cause of the sleep apnea. So I already mentioned that reducing alcohol or avoiding alcohol will make sleep apnea much worse. And that previous slide that I showed you with a very severe sleep apnea, that person was having a lot of alcohol. So simply, if you are having a lot of alcohol, reducing or even avoiding alcohol could very much reduce the amount of sleep apnea, or even stop. If you're having a large amount, it could be the cause of your sleep apnea, and therefore not having that alcohol could stop the sleep apnea. As I mentioned previously, obesity and being overweight is one of the main causes of sleep apnea. So doing things that help your weight management and losing weight can be curative, but weight and sleep apnea are very much a two-way relationship. So whilst having the extra weight can cause sleep apnea, when you already have sleep apnea or anything that disturbs your sleep, it can make it much easier to gain weight and much harder to lose weight. And there's a variety of reasons for this. If the sleep apnea is causing you to be very sleepy, then the chances are that you're also not feeling like doing a lot of movement. Any movement that you try and do is probably not as effective as it would be if you got lots of energy. It can also make you gravitate towards high calorie, not necessarily healthy foods, because they can give you an energy boost. They can make you feel a little bit better and just give you a sort of a boost to your mood when you're feeling down, because let's face it, when you're sleep deprived, anybody who's sleep deprived probably feels rubbish. And sometimes a bit of chocolate or cake or other things that aren't good for our weight, it's just all you're craving because you just want to feel a bit better. It also messes with other hormones, so it can make you more hungry, and it can make you hang on to your calories because it increases your stress levels, and we know that stress levels are very important for our weight as well. So the more stressed you are, the harder it is to lose weight. So stress management I should also put on there. Finding ways to relax and to wind down in an evening is going to help with your sleep. Smoking is an irritant to the airways, and this can also cause or promote sleep apnea. It can make it harder to breathe through your nose as well, which we've already said can promote sleep apnea as well. And if you smoke, you're more at risk of things like COPD, and having COPD and sleep apnea is much worse than having one or the other. There's an additive effect of those in terms, again, of your risk for early death and for other complications. So we would always advise to make use of smoking cessation services, using perhaps nicotine replacement therapy to help you and support you to stop smoking. And then I've put on here caffeine. Now, the amount of times I see on people's questionnaires that people are having lots of caffeinated drinks and they're having them late into the night. And caffeine actually has a profound effect on our sleep. So it blocks the receptors in the brain where a hormone called adenosine that builds up in the day and tells us it's time to go to sleep and helps push us into deep sleep. Caffeine blocks the same receptor. So it can really make it harder to get off to sleep, but also affect the quality and the deepness of that sleep that we can get. What a lot of people don't realise is caffeine has a very long half-life. So we talk about a half-life is the time it takes us to get rid of half of a drug in our body. So for our body to metabolise it and get rid of it. And in the case of caffeine, this is about 6 to 8 hours. So if we just go on the shorter time of 6 hours, you have a cup of coffee, for instance, at 12 midday. At 6 p.m. you've got half of it in your system. At midnight you've still got a quarter of it in your system. So if you're having caffeine late into the afternoon or into the evening, it is going to have an effect on your sleep. So whenever anybody's having any issues, particularly about initiating sleep and getting off to sleep, but even just quality of sleep, I would always recommend trying not to have caffeine after midday. So this includes tea and coffee, but it also includes things like cola. I have a lot of people saying to me, but I have diet cola or sugar-free cola. The amount of sugar in your drink is not the same as the amount of caffeine. So cola, unless you can get decaffeinated, but you don't see it very often. It's usually certainly in Coke, you get it in a gold sort of wrapping. And things like Iron Brew and energy drinks as well are all going to have an effect on your sleep, and it can get a vicious cycle. So you're sleep deprived, so you feel like you need the boost and you need the caffeine to keep awake, but then that's going to keep you more awake and make you more sleep deprived the following day, driving you to want more caffeine. And it's, you know, it's what time you decide to get off that circle and that roundabout. I would always recommend, if you do drink a lot of caffeine, you don't go cold turkey, because you will feel even more tired. You feel absolutely exhausted. If you just stop drinking caffeine, if you have a lot, you're also likely to get a banging headache that doesn't easily go away with painkillers. So I would recommend to anybody who does have a lot of caffeine to cut out your last caffeinated drink. Have something that's decaffeinated or not caffeinated, just the last drink for a good few days, then cut out the next one and the next one until you get earlier and earlier in the day, till you're not having anything sort of after that midday time. I am going to do another presentation more about sleep and sleep hygiene, and for people who are just having problems with getting off to sleep as opposed to those with sleep apnea, and I'll put another presentation on the website as soon as that's done, so have a look out for that. For some people, particularly those with more kind of moderate or mild sleep apnea, they might only have sleep apnea when they're on their back. Because when you're on your back, gravity is pushing, helping that jaw fall back, the tongue fall back, the weight push on the neck. And when they're on their side, they're actually fine. The problem is sometimes you might start off on your side and then you roll onto your back while you're still half asleep, and then end up staying on your back. So sometimes people can do a variety of things, and you can see somebody's put a little ball in the back of their pajamas. You can wear a belt, or you can buy fancy things, but I wouldn't recommend those because they're expensive and probably no more effective than the homemade items to stop you staying on your back. So it's going to be really uncomfortable if the guy on the top right rolls onto his back, because that ball's going to dig in, and it's hopefully going to make him just turn and carry on turning onto the other side. So the gold standard treatment for sleep apnea is something called CPAP. So CPAP, what we call it CPAP, which stands for continuous positive airway pressure. And what this involves is wearing a mask, and I'll go into the masks in a second, but basically the mask is delivering air, and you can see air by these arrows into the airway and splinting open that airway. So looking at these pictures, we've got an open airway here, we've got an obstructed airway here, and then when they're wearing the mask, the pressure of the air is keeping that airway nice and open, so that you don't need to keep waking up to get breathing again. So you should have a much better quality of sleep, and also we're protecting the body from that repetitive dropping of the oxygen levels. So there are a variety of CPAP masks, lots and lots, and we're quite fortunate at Salford that we don't sort of go with just one manufacturer, so we do have a big variety. That said, what mask suits one person doesn't suit another, but what we do ask of you is that whichever mask you decide, if you want to go with CPAP, we will try the mask with you in clinic, and that you have a really good try with that mask before you ask for another one, before you ask for a change. So we do sometimes get people phoning up within a week of having the CPAP saying, I can't tolerate that mask, and they've not really given it enough time or preparation. The reason we ask that is, you wouldn't think it when you look at it, that these masks are all, most of them, more than £100 each, and so you can imagine how quickly that money adds up, and we do have very limited resources, hence why we've not got enough staff to have got you through this waiting list as quick as we would have liked to. Essentially, masks come in a couple of different types. you saw in the picture before something called a nasal mask. And these are what we call nasal cushions, or we have nasal pillows, and they just sit under the nose or just perhaps into the nose. Or we have a more standard nasal mask that sits around the nose. So the advantage of all these nasal masks is that we are encouraging you to breathe through your nose, which will protect the back of your airways. They're a lot lighter, more comfortable, easy to get a good seal with, because basically what we need to do is make sure that there's no air leaking out of the mask except for where the ventilation holes are, so that we can get a pressure into that airway. Generally, you need to have less pressure coming from the machine and they control things better. The difficulty with nasal masks is you do need to breathe through the nose. If you don't breathe through your nose and you try and mouth breathe, you're going to leak air back out of the mouth and it won't feel particularly pleasant. For some people, that makes them just go, "Ooh, that feels a bit odd," close the mouth, carry on. For other people, it feels horrendous. They feel like they can't breathe properly and they're going to rip the mask off. So with those people who absolutely cannot breathe through their nose, then we have to use something called a full face mask. So we have, these are called hybrid masks. So they look a little bit like the nasal mask, but they cover the mouth as well. So these are the Dreamwear masks, and they literally are the same mask but with a slightly different cushion that covers the mouth. So the advantage of this is if you wear glasses, you can put your glasses on if you wanted to read or watch TV whilst wearing your mask. And the reason why I think you might want to do that is if you are struggling to use your mask and fall asleep with your mask, then the time to get used to it is not at bedtime when you're desperate to sleep. So you might want to do a bit of acclimatization when you first get the mask by bobbing it on and doing something else that takes the mind off the fact that you've got this mask on your face. So that could be watching TV, reading a book, something that's going to help you get used to the mask without you just concentrating on the mask at a time when you're wanting to sleep. And then the more standard full face mask is this kind of triangular looking thing that fits over the nose and mouth. The advantage of that one is the pressure's delivered over a bigger area, so it doesn't feel quite as snug on the face, but obviously it's a bigger, clunkier mask. So these are just some examples of the masks we have, just for you to have a little think about what you think might suit you. Or you could just go all in like this guy did and make your own mask. So I mentioned CPAP, but actually we have different types of what we call PAP therapy, so positive airway pressure therapy. So CPAP usually refers to continuous pressure, where the pressure the machine's delivering is just the same pressure over the entire night. We often also use something called APAP, so auto titrating, where the machine's constantly adjusting itself to find the right pressure to what you need. So it'll usually start off quite gentle, and then as you start falling asleep and your airways start collapsing, it increases the pressure to what you need. There are pros and cons with each type, and so we will choose which we think will be best suited to you. And I'm going to talk a little bit about how we pick this pressure in the next slide. And then there will be some people who need something called bilevel CPAP. So instead of just having one pressure, so this is a pressure when you're same pressure when you're breathing in and out, this will have two pressures, a lower pressure when you're breathing out and a higher pressure when you're breathing in. And these machines can go up to higher pressures as well. So a normal CPAP or APAP can go up to the pressure of 20 centimeters of water. The bilevel ones can go up to 25. So these are good for people who need a lot of pressure. They're also good for people who need a little bit more of what we call pressure support. So those people who are having a little bit of that hypoventilation I mentioned right at the start. So quite a few of you will have something called an auto trial. So your machine will start off as an automatic machine, varying the pressure. So this is sort of over days, the pressure that the machine's delivering. So we set in a minimum and a maximum and letting the machine find that pressure. And then after a set period of time, usually 2 weeks, but 2 weeks of when you've got this kind of minimal level of usage, the machine will flick into either a CPAP or a C-check mode. So this is the pressure that you've spent about 90% of the time at, will be the pressure. But what this C-check will do is if you're having lots and lots of apneas on that pressure, it's going to start rising the pressure up to a maximum of 3 centimeters different to what it was originally set at. And if you're having really no events at all, then it will decrease it. So it can go up or down by plus or minus 3 centimeters of water. So it can still adapt somewhat to your situation. So another treatment for sleep apnea, which can be helpful for people who've not tolerated CPAP or don't want to try CPAP. It's more helpful to those with snoring, mild or moderate sleep apnea, although there's no funding for people at all for pure snoring. Is this thing called a mandibular repositioning device, or you might see it as a mandibular advancement device, intraoral device, mouth guard, gum shield. It comes with different names, but it's all the same thing. The way this works is basically it pulls the jaw forward and helps open up that space at the back of the throat. The issue we have with these at the moment is that there isn't proper funding even for sleep apnea for these. So the options really is that you can buy something like this. I think this one's about £70. You can get even cheaper ones at about £30, but I can't recommend any particular brand. We haven't, they haven't been tested. Some people do find them helpful. What it is helpful sometimes is to know that you can tolerate having something like this in your mouth before going down the line of a more expensive device. I would always advise anybody who wants one of these that you make sure you've had a recent dental checkup, that you're not needing any dental work, because even with the over-the-counter type devices, you do mold it to your current teeth. So that's obviously going to change if you have fillings, extractions, bridges, etc. So you do want to have your teeth checked and make sure you don't need any dental work done first. We can then refer you to the dental hospital to make this something called a monoblock, which is this type of device. So it's quite a bulky device, but it is custom made, but it's monoblock, it's all one piece. So it's in a fixed position, and this would be done by the maxillofacial department at Manchester Royal. And then the sort of higher level device is this sort of custom made adjustable device. So with this particular device, you change the straps on this to bring it further and further forward. So you do that over a bit of time and allows you to make that adjustment. Unfortunately, these ones don't have any funding at the moment, so would require referral to a private dentist. So we can refer you to a particular dentist at Bupa, but this will set you back just shy of £1,000, including all the dental fees. So thank you for keeping your attention. Last bit, and probably but a very important bit, is about driving. So it's estimated in the UK that about 15 to 20% of accidents and up to 23% of all deaths and serious injuries as road traffic accidents are caused by excessive daytime sleepiness. And people with sleep apnea versus those without sleep apnea are thought to be at a 2 to 3 times overall risk of having an accident. Just stick with me for a minute though. So does everybody need to inform DVLA and stop driving? Well, the answer is no. So The updated DVLA guidelines are making it really clear that they're only interested in patients that are having excessive sleepiness that's having or it's likely to have an adverse effect on driving. So if you are falling asleep at the wheel, obviously you should not be driving, and it is driver responsibility to ensure that you're fit to drive, and that means having full control of the vehicle that you're in. But if you've never had any issues with feeling sleepy whilst you are driving, then you do not need to stop driving. You do not need to inform the DVLA. You just need to make sure you're making that assessment every time you get into the car. And we look at whether should we stop driving altogether, or should we just make sure we're practicing safe driving. So this might for some people mean that they only do short distances, they only drive a time of day when they know they're more alert. So some people feel more alert in the morning but don't drive at night. And it's about making sure you've got adequate nighttime sleep, and if you need to have naps, having naps, particularly if you need to drive. But it's about safety. It's not about having a heavy hand and stopping people driving if they're able to drive, but it's about making sure people aren't driving if they are at risk of causing an accident which could hurt or even kill themselves or another road user. So who should inform the DVLA? Well, as I've already said, not everybody has that level of sleepiness, and just to prove that the severity of your sleep apnea does not correlate with severity of symptoms, this is a plot of about 10,500 of our patients from sleep studies for sort of the last 13 years, where I've plotted the severity of their sleep apnea by that AHI criteria. So that number of breath pauses per hour against the number of points they've scored on the Epworth Sleepiness Score, which is that score you'll have all filled in about how likely you are to doze off in different situations. And as you can see, for every sort of level of severity of sleep apnea, we've got pretty much every point on the Epworth score, and vice versa. And the American guidelines particularly say that the sleepiness score alone is also not likely to be adequate, because it's very subjective. So, you know, we do see quite a big difference in that score when we start talking about driving to patients, that suddenly that score's reduced massively compared to what they came in with when they think it might have an effect on their driving. So if you have a very high sleepiness score, then you probably need to think about whether it is impacting your driving. So other things to think about if you're doing any of these maneuvers. So if you've got sort of, like I say, already sleeping, so you are very high on your Epworth score, or in other situations, if you've already had a collision or a near miss that's attributable to sleepiness or inattention, then that might suggest that you do have sleepiness that's impairing or has the potential to impair your driving, and you must not drive if you're in this situation. And again, we recognise that this can be variable, but it's really important that you don't push through and think you'll be okay. You are as liable by law as if you were drunk driving if you do cause that accident by driving. Other things, so if you feel yourself, your head nodding, you're hitting the rumble strip on the motorway, you're regularly using manoeuvres to try and keep yourself awake, having hot drink, coffee, having to get out and go for a stretch, opening the window, putting loud music on, keeping your legs moving. These are all signs that you're fighting something. And if you're having to do this frequently, as opposed to, you know, every few hours on a really long journey, then again, you do have sleepiness that's impairing your driving or potentially impairing your driving, and you need to practice safe driving or stop driving, and you would need to inform the DVLA of your condition. So another practice of safe driving, if you have sort of these symptoms, is to make sure you're not doing long monotonous motorway journeys, which are much more risky than little short journeys. So who's responsible for informing the DVLA? Well, it's the driver that is responsible for being honest with your symptoms and self-reporting yourself to the DVLA. So the only time that a sleep specialist or doctor would get involved in informing the DVLA is where there's a serious public safety risk, where a patient has been advised not to drive, where we're pretty sure that somebody shouldn't be driving. So I have had it where I had a taxi driver in front of me who couldn't stay awake while I was fitting a CPAP mask to them. They should not have been driving. That sort of situation, and then we know that the patient is still driving against that medical advice. It does negate your insurance if you drive against medical advice as well, and that's the only time that it really is a last resort thing. So as a patient, you need to report your symptoms honestly to help us gauge whether you do need to inform the DVLA. And we usually advise the best time to actually inform them is hopefully once you're established on treatment. So if you stop yourself from driving, make sure you're practicing safe driving before you get onto therapy and feel brilliant on therapy and there's no symptoms anymore, you do still need to inform them, but you're going to inform them from a position that you're already on therapy, your symptoms are controlled, and so they'll have no issues around you keeping your license. You just need to make sure when you're completing the forms, which you can either do as a paper form or you can do it online, that you make sure you tick that you are no longer sleepy, that you don't have any sleepiness that's affecting your driving now. So hopefully that's all been reassuring. I know there's a lot of information there, and you will be able to go back and re-watch this video at any time that you want to, as long as you've got the internet access. But I'm going to now open it up to questions.